everyone, and welcome to your lecture today on gender and health. I'm your guest lecturer, Mariam Habib. Let me begin by apologizing for the delay in these lectures. I was struggling with some health issues and trying to juggle my professional commitments. Hence, I could not record this lecture on time. However, thank you so much for your patience, and here I am. Unfortunately, also, as is the way for most of these things, Camtasia was not working for me, so I'm using a new software called Panopto to record this lecture, and it records side by side. So you might see that the slides are a bit smaller than what you're used to. So I would encourage you to either go full screen so you can read the slides properly, or then you could just look at the slides on Moodle and follow my lecture together with it. So I will share my screen and let's begin without further ado. So here we are, week 12, gender and health. Just to contextualize where we are, you know that this is the section populations in focus, where we learn about global health leadership, maternal health, and differential health outcomes. A little about me. My name is Mariam Habib. I'm originally from Pakistan, where I've completed my medical degree in 2012. Additionally, I read my master's in public health at the University of Leeds in 2015. Cumulatively, I have 3+ years of experience working in sexual and reproductive health in LMICs, and presently I'm the scientific coordinator of wissenschaftliche Mitarbeiter at the Center for Global Health at TUM, and please feel free to get in touch. So, just a small overview of this lecture. Sorry, these slides seem to keep moving. I've divided the lecture into 4 parts: an introduction. The second part is the reproductive, maternal, newborn, and child health. The third part is global health leadership, and finally, addressing gender and health. So, let's begin. Um, in the introduction, let's start with a small overview of sex and gender. Of course, you know sex are the biological and physical characteristics. These are not definitions that are new, but it's worth reiterating, I feel. While gender is the socially constructed and it's influenced by laws, politics, policies, communities, and families. In general, the concept of gender always has a social or culturally constructed difference between males and females, and the beliefs, practices that are associated in each culture with what masculinity and femininity means. As global health practitioners for the future, what is important to us is to remember that gender is a key driver of power to exercise the right to health, including exposures to risk of poor health, health seeking behaviors, and to access to quality healthcare and outcomes of health and well being. Again, as future practitioners, we have to remember that a lack of understanding of the complexities of gender and the extent to which gender inequality is embedded in our institutions is evident by who leads global health organizations, what programs they undertake, and what they fund. And we will talk a bit more about this in our second section, global health leadership. Of course, the interaction between sex and gender encompasses that sex has a biological dimension, which is the differences between males and females that are purely physical and are relevant, biological, and are relevant for the diagnosis and treatment of various diseases and medical conditions. The social dimension, which encompasses gender, has the factors that influence health that lie outside the biological constraint. Important social issues, for example, in today's day and age, are education, employment, transport, and agriculture, both of which encompass gender for men and for women in a different way. Socioeconomic, educational, cultural, and ethnicity differences can impact patterns of behavior and access to resources. Of course, the interaction between sex and gender in the context of COVID 19 is very important. And in the midst of this global pandemic, the Global Health 50/50 gives us a good overview of how sex and gender interact in the context of testing and treatment and approaches to health in COVID 19. So please have a look. When speaking about gender equality and gender health, we must speak a bit about equality and equity itself. Gender equality in health means that all people have the right to realize their full potential to lead healthy lives, to contribute to health development, and benefit from the results of this development. Gender equity in health means fairness in addressing different health needs of people according to their gender. We must remember that inequitable health outcomes are unacceptable, but a concept of fairness recognizes that there's differences between the sexes and resources cannot always be allocated equally, but sometimes have to be allocated differentially to address unfair gender disparities. Of course, gender disparities occur across the spectrum when we talk about gender norms and inequalities. Here's a table about the top 10 DALYs, or disability adjusted life years globally for 2010, blue being males and red being females. Of course, across the spectrum, you can see that males in general are experiencing more DALYs than women. But have a look at road injury, where males are twice as more likely to have DALYs because of road injury or road traffic accidents than women. This can, of course, be defined through differences in access of vehicular transport between men and women, the different modalities and mobilities of how men access road traffic, and how women access road traffic. And perhaps it could go a long way in explaining why so many men account for DALYs in road traffic than women do. But again, this sort of gender lens is very important to keep in mind when making strategies, policies, and practices to combat the global health and the public health priority of road injury. Another one here is the proportion of DALY's burden, attributable to risk. Again, blue being men and red being or orange being women, we can see that across the spectrum, men in general have more attributable risk than women. But have a look at tobacco smoke and alcohol and drug use. As you can see, men are twice as more likely to have attributable risk for tobacco smoke, for alcohol, and drug use. Perhaps this is a gender stereotype that men tend to smoke more or use alcohol or use drugs more. But in this sample size, and it is scientifically proven that they do. The point that we're trying to bring across is that the gender lens is not really only limited to women's health. And when we apply a gender lens to studying health, we help not only women's health, but also men's health. So, what is the concept of gender and health, and what is its interaction? Conceptually, gender has been defined as influencing health and well being across three domains through its interaction with the social, economic, and commercial determinants of health, via health behaviors that are protective of or detrimental to health outcomes, and in terms of how the health system responds to gender, including how it affects the financing of and access to quality healthcare. Then, why women's health? We study women's health because we believe that the health of women has a direct bearing on the health of the future generations, their families, communities, and ultimately larger society. But we must contextualize global health and women's health together. Traditionally, we've seen that the model of clinical research, for example, has always seen men as subjects and extrapolated their research to women. And today we find out that perhaps that strategy has not worked well for us. In fact, the economic and the social cost of problems unique to women remains understudied. In many cultures across the world, women occupy a socially weak and marginalized position, and hence, if we study women's health contextualized within global health, it's a step towards creating equity, and it's one more step towards closing the health and gender gap between men and women. So now we come to our first section, reproductive, maternal, newborn and child health, or RMNCH. What is RMNCH? RMNCH is the field within population health that encompasses the life stages and health events that take place from pre-pregnancy through the first 5 years of a child's life. I'm sure you're familiar with MNCH from your previous readings and from what other reading material you've come across. However, in the past 20 years or so, the WHO and other global organizations realized the importance of the reproductive health or the reproductive period within a woman's life as a gatekeeper for many of the illnesses and many of the approaches for health promoting choices that she makes. So then there was a consensus to include reproductive health within part of this definition. So, hence, now we have RMNCH, which encompasses the reproductive health, which pertains to the reproductive processes and systems throughout all stages of life and not just childbirth and pregnancy. Then we have maternal health, that refers to the health of mothers during pregnancy, during childbirth, and in the postpartum period. The newborn health refers to the health of a baby during its first 28 days of life, while child health pertains to the health of children from birth. Of course, there's an the why do we study RMNCH? We need some context. Contextually, maternal health are the second largest killer for women during their reproductive age. 99% of deaths in pregnancy or in childbirth are in developing countries. In developing countries, maternal mortality ratio is 239 per 100,000 births. Contrast this with developed countries where it is only 12 per 100,000 births. 830 women die every day because of pregnancy and childbirth related complications. The five main reasons of death in pregnancy or childbirth are severe bleeding, infections, unsafe abortion, and medical complications. Risk factors for maternal and newborn mortality include simply living in low and middle income countries, especially in the rural areas where there's very little access to health services, poverty, and pregnancy at either extreme of the reproductive age period. Risk factors for children dying under 5 include living in rural areas, poverty, and having a mother who did not receive basic education. In 2017, more than 1 in 10 married or in union women globally had an unmet family planning need, and less than half of the total demand for family planning was met with modern contraceptive methods in 45 countries. As we can see, we lag truly far behind. The WHO has compiled 10 facts on maternal health, which gives a good reading to contextualize how far we truly do lag behind. And why is that? Historically, healthcare providers and communities, especially in more traditional and more conservative cultures, they have focused most of their attention on the moment of childbirth. In many cultures today, including mine from Pakistan, they view the components of what is now known as RMNCH as life events and not health events that require medical guidance, active monitoring, or intervention. There's challenges to improving RMNCH, there's underreporting and poor quality of data collection, which is a big problem, especially in LMIC contexts, which severely affects tracking RMNCH service delivery and outcomes. Monitoring and reporting may further be complicated with different stakeholders who use different definitions for various time periods in the cycle of care. Due to poor health management and information systems and lack of centralized and digital health systems, there's a dearth of reliable and complete data. LMICs often use modeling to estimate mortality rather than using true data. Then what happens is that many women and children live with untreated health conditions which are overlooked as a result. And hence we continue to have these challenges. However, outcomes can be improved. Here we look at five modalities of how RMNCH outcomes can be improved. For example, nutrition. This could include supplementation of foodstuffs or fortification of foodstuffs. For example, adding iodine to salt to prevent goiter growth. Reproductive health and family planning. Of course, family planning being the information, the means, and the tools required for couples to decide how many children to have and when to have them. Adequate birth spacing, which allows a woman the choice to have a sufficient number of years between the birth of her first child and the birth of her next child, allowing the optimum health for the mother and for the child. Of course, contraception, which allows her reproductive agency and choice, having all the means, the modalities, and tools to decide when to have children, how many children to have, and when to stop having children, or if not to have any children at all. Then, of course, sexually transmitted infections, counseling when one has an STI, and then treatment modalities to treat it. Of course, accessing antenatal care and quality antenatal care within the pregnancy period, and of course, childbirth, safe, secure, aseptic childbirth, and then postnatal care. Within countries, access to care and outcomes can be different between different ethnic groups, religious groups, rural and urban areas, and of course, male and female children. For example, in 2015, the proportion of births attended by a skilled birth attendant differed by 37 percentage points or more between the wealthiest and the poorest subgroups in half of the country. Higher income groups are also more likely to access antenatal care. People in urban settings are 10% more likely to access RM and CH services than those in rural areas. In 2015, women who had received secondary schooling were twice as likely to use a modern form of contraception, and their children were 39% less likely to be stunted than children whose mothers have received no education. Of course, we are making progress. In the context of the UN, the Sustainable Development Goal 3 and Sustainable Development Goal 5 seeks to reduce maternal mortality specifically. SDG 3 strives to reduce the global maternal mortality ratio to less than 70 per 100,000 live births by 2030 in the WHO's Sustainable Agenda for Health. And it ensures that no country will have a maternal mortality rate twice the global average. Of course, we've made some strides. In 1990, we had a maternal mortality rate of 385 deaths per 100,000 births in low and middle income countries, while now we have 216 per 100,000 births. This is progress, no doubt. However, we have quite a ways to go. How do SDG 3 and SDG 5 interact with global goals across the three domains of health that we spoke about before? Here's a very interesting bulletin on the WHO's 2030 Agenda for Sustainable Development that gives an overview of the interventions that one can have in SDG 3 and SDG 5 and how they interact with global goals and other SDGs. When we talk about reproductive health, of course, there is always a fear that a woman will and her health will only be limited to her reproductive cycle. Of course, in throughout the years, we've seen that there is a global focus on reproductive health. What it has now, unfortunately, we have realized that what it's been doing is it reduces women's health concerns to only the reproductive aspects of their life cycle. It shifts the focus away from the socially productive tasks of women and negates the critical needs of women throughout the life cycle. Policy and practice then becomes out of context from the real needs of women and renders the results unsatisfactory and unacceptable by the women it targets. For example, family planning programs that focus on birth controls, they completely negate that women's lives are bound to the family and society and reduces the name of family planning to simply a question of birth control methods. There's a lack of attention to non reproductive health. A number of non reproductive illnesses and injuries are primarily associated with women. However, these health problems are less likely to be detected or treated because practitioners have a narrow framework they use in considering healthcare for women due to lack of awareness regarding the extent of women's healthcare needs and how comprehensive those healthcare needs need to be. There's a global pattern of treatment of women. Um, Women are expected to conform to global expectations of normative and ideal gender roles. There's a tendency to define women by their marital status throughout the world in high income and in low income countries, in conservative and more looser cultures. By and by, young girls are socialized to prepare themselves for spousal and maternal roles, and such kind of expectations decrease the potential for promoting and supporting educational or career goals, and this increases the potential for status and power issues throughout a woman's life. Women are also re essentialized to caregiving roles. It is expected that women will be the primary or sole care providers for children, for spouses, for parents, and for the elderly in their families. And in many cultures, this extends to not only their family, but the spouse's immediate and extended families. Women are expected to be primary teachers of sound health practices for future generations and first gatekeepers for preventive, promotive, and curative healthcare. However, we must realize that these responsibilities are additive and not substitutive. What happens is there's an overload of responsibilities on women, there's limited time, energy, and resources to attend to personal needs. And overall, women neglect not only their own health, but we have a society that does not cater to women's needs within the gender context as much as it should. There's an interesting dichotomy of roles in this context within the world. Women who work extended hours as spouses or as mothers are labeled as non working women or housewives. This fails to take in consideration, for example, those female farmers who also carry the major bulk of domestic work or subsistence farming and are paid minimally for it. Or, for example, nurses, teachers, clerical workers, for which the income does not match their worth or their work. These no or low income positions bring with them limited resources and a lack of regulatory policies to protect women, and do not give women the space to negotiate better health. At this point, women are either not aware of their healthcare needs or ignore these needs because of the conflicting responsibilities, the workload, and other caregiving activities that are often to their only and wholly solely their burden. Sometimes women are prevented from seeking health care or from maintaining their health by limited resources and structural constraints. Personal health hazards make women more vulnerable and thus remain obscured until women show symptoms that are related to their reproductive health, which makes all their illnesses more legitimate. For example, throughout their life cycle, women face nutritional problems and eating disorders, face infections, face gender based violence, have issues with occupational health. But often these are not contextualized properly, especially when they are taken outside the non reproductive health or the comprehensive care strata. The bottom line is whether women are working inside or outside the home, their work continues to be unacknowledged, invisible, and devalued. When we talk about the invisibility of women and their health, let's talk about a few cases that we see every day amongst ourselves. Number one is the COVID-19 pandemic. Recently, we've had some evidence come to light that says 77% of the staff in the NHS hospitals are female, and many of them have warned that the PPEs, so personal protective equipments, that have been procured for them does not fit them. Most healthcare workers are failing the fit test for the FFP2 or 3 masks or respirators, as they are known. Since most of these PPEs and these masks are made for the male form, they do not fit the female. There's often leakages or incorrect fit, which which means that they are at a higher risk for contracting COVID when they are administering to their patients. Case number two is the periods myth. Here I quote Caroline Criado Perez, who wrote this very interesting book called Invisible Women: Data Bias in a World Designed for Men. Here I quote: even painful periods, which affect 90% of women, aren't taken seriously. Criado Perez uncovered a small 2013 study that found out that Viagra, sildenafil citrate, provided female participants 4 hours of pain relief from menstrual cramps without side effects. The lead researcher of this study applied for a larger grant and additional funding but was continuously rejected. One of the reviewers commented that whether painful periods were a priority public health issue at all. Another case is the transport divide. Adolescent girls and young mothers in the global south have to access spaces outside the home for decisions to continue education, employment, and to access healthcare. Walking and public transport are the most used transport modes for women, but rarely do they get as much focus in transport planning by transport planners than roads, highways, or bridge building projects that are usually for trucks, cars, and vehicular traffic that are mostly male dominated. Women also have a lack of safety, a fear of sexual harassment, and they have cultural issues and financial constraints that affect their daily mobility. And in the end, this gender concept also affects the way women make health promoting choices and the way women approach health. Gender based violence is a big concern in many settings. Recently, again in COVID, there has been emerging evidence that gender based violence has increased in lockdown as women and children are forced to be locked down together with abusive partners and to spend more time in their company. Healthcare workers who test for COVID 19, especially in low and middle income countries and in sub Saharan Africa, are facing attacks and harassments by people as they think they are carriers. In my country, Pakistan, one of the 6 countries that still has active cases of wild polio vaccination workers in Pakistan and our neighboring country, Afghanistan, are overwhelmingly female due to cultural restraints on men accessing household. However, they are attacked and even shot at a regular basis by people who have misinformation, who have distrust in the health authorities, and this classifies as gender based violence against these women. And now we come to the next section, global health leadership. And here we discuss how the leadership is, who the leadership is, what programs they undertake, and how we can, and maybe some part of how we can manage and address the invisibility of women. In global health leadership, I would like to have a focus on the Global Health 50-50 report from 2020. This is a WHO led report that is an unprecedented bird's eye view of the global health system today. It reviews gender related policies and practices of 200 global organizations and looks at their internal workplace policies and parity measures for gender. This is a fairly large sample size and covers organizations from 10 sectors headquartered in 33 countries across 7 regions. So, the first question is, how global is global health? Here we have a look at the headquarters of 198 global organizations that are active in health and health policy across the globe. As we can see, 38% of these are headquartered in North America and 46% in Europe, while only 5% in Asia, 7% in Sub Saharan Africa, and 1.5% each in Latin America and Middle East and North Africa, where the bulk of implementation of global health takes place and where the bulk of the overhaul of global health and health system needs to take place. Additionally, when we look at the national income level of headquarters by sector, we can see that most of the HQs and most of the incomes are very much concentrated in high income countries. Public private partnerships, private sector, bilateral and global multilaterals, consultancies, philanthropy and funders, and most tellingly, the UN systems are almost completely or entirely located in high income countries. When we look at the geography of global health leadership, it is a stark contrast and a stark picture. Low and middle income countries are 83% of the world's global population, while high income countries are only 17%. However, only 5% of global health leaders are women from LMICs. And 50% of the total global health leaders are nationals of just two countries, the UK and the US, which perhaps makes a lot of sense when we look at our first slide, where more, more than 70% in totality of the global health headquarters were located in the US and the UK. Only 8% of the degrees from global health are obtained in LMICs. And this is the same as all degrees, and 8% of degrees from Harvard are the same as all degrees from LMICs combined, 92%. This shows how long a way we have to go in global health, especially in the most vulnerable countries and in those LMICs where most of the implementation and overhaul of the health systems needs to take place. When we look at parity for male and female leadership, we see that it is still overwhelmingly males who lead global health organizations. 73% of males are CEOs in global health organizations, and 68% of board chairs in global health organizations are also male. 7 in 10 global health leaders are male. Decision making bodies are disproportionately male, and we can see that in general there is always more men than there are women, and there is a lot less parity in governing boards and in senior management. At the current rate of change, it will take over half a century to reach gender parity in senior management. So, really, what is the bottom line? The bottom line is confronting the 70, 80, 90 glass border in global health. More than 70% of the leaders in this sample were men. 80% were nationals of high income countries, and 90% were educated in high income countries. And this is the power and the privilege and the priorities of global health as we see them today. So let's see, how can we address gender and health? Do these organizations themselves, do they disaggregate their data on programmatic delivery? As we can see, 38% do fully disaggregate data, but starkly 31% don't disaggregate their data at all or don't commit to disaggregating their data on sex and gender lines. When we address gender and policy in practice, do organizations specify a population focus in their programmatic priorities by SDG target? It is again a telling picture. Of course, many organizations are at the forefront, and they are committed to end violence against women, to end maternal mortality, to increase access to SRHR, to increase access to universal health care. However, almost just as many, if not more, organizations have no mention of sex and gender in their programmatic priorities. This brings us to the fact that gender needs to be transformative. And as global and as future global health leaders, we really need to look at gender transformative strategies for the future. How can we do this? Number one, the idea is to move beyond equating gender with sex. As we spoke in the first part of this lecture, Gender is a social construct, while sex is a biological difference. But more tellingly, gender as a social construct is a driver of inequity, and we have to realize that at present there's differential levels of power between men and women because of the concept of gender, and this gives them different parity and gives them different negotiation power. So we always have to keep this in mind when making policy in practice. Another part would be holistic action and analysis on gender. We should apply the gender lens on three domains of health that we discussed in the first part of this lecture: the social determinants, the health seeking behavior, and the service delivery and health system responses, especially when it comes to finances and access to healthcare. Sex disaggregated data, as we can see, many organizations are fully committed to presenting. However, there needs to also be an analysis of sex disaggregated data with a gender focus. For example, global health journals could encourage a gender analysis of sex disaggregated data for all publications. There could also be a push for research on how social construction of masculinities and femininities shape men and women's health. Of course, we must realize the gendered nature of the workforce. At present, we could formulate gender-sensitive policies and health professional regulations across all levels of the workforce. There needs to be a push for increased leadership roles for women and decent conditions of work for all, and not just for women. We can re-envision and integrate policy structure, this means that we transcend disease-focused approach and look holistically as health as a whole that interacts with the social determinants of health. And we must engage with policymakers on a broader level, not just the ministries of health, but really look at the stakeholders of health, NGOs, private and public partnerships, and engage with them on a broader level. Then there must be transparency and accountability. There can be agenda focus and national reviews in the UN Development Assistance frameworks. And the Global Health 50/50 report is just such a platform that can be expanded upon and can be contributed to when countries themselves have a commitment to have a gender focus and to have a gender lens on their policy, their practice, and their strategies. So here are the references that I used. Of course, all pictures are the property of their rightful owners and only reproduced here for educational purposes. Thank you so much for your patience with this lecture. This is my first time, and I apologize if I was too quick with something, or perhaps if any concepts were left untouched. Please feel free to feedback at the email address given below. I am associated with the Center for Global Health at the Institute for Medical Microbiology, Immunology and Hygiene at the TUM based at Krogerstrasse. Please feel free to book an appointment and drop in for any related questions or queries as well. Thank you so much. Thank you so much for this opportunity for this lecture. I hope that this has helped contextualize gender and health, and I hope it has brought up some good points for discussion. And I would love to have a Q&A session if you wish, or any live session or webinar where I can touch upon my own, a lot more upon my own experience in LMICs, especially in Pakistan, and my more recent experience in Sub-Saharan Africa, including Gabon and Ghana. So please feel free to get in touch and have a good day today. Goodbye.